It's my pleasure to talk about same-day initiation of antiretroviral therapy. I think we've really had a great experience in London in particular, in central London, of initiating therapy very quickly when someone receives an HIV diagnosis now. And this is one of the many factors that's led to us seeing a reduction in the diagnosis rates in men who have sex with men in our central London clinics. So what do we know in terms of guidelines around same-day initiation? Well, the IAS guidelines recommend rapid or immediate start of antiretroviral therapy upon the diagnosis of HIV infection, and they say that treatment should be initiated as soon as possible after the diagnosis, including immediately after diagnosis, unless the patient is not ready to start therapy. One of the things I say to my patients now when I see them when they're newly diagnosed is that we throw a lot of medicine at you very quickly. We get your viral load undetectable, we give you a good life expectancy, but don't be surprised if some of the psychosocial issues around your HIV infection turn up a little bit later. So I'm a little bit cautious about saying to someone, you'll be stable when you're undetectable, and even though we start immediate therapy, I make sure that I see people more frequently in the first year after diagnosis because of some of those other issues that sometimes drop out at around the 6 or 9 month mark. So very important that the patient is ready to start treatment. This is not a one-size-fits-all approach, and we have to ensure, even though we've only met someone very, very briefly at the first visit, that they are in fact ready to commit to lifelong therapy. And indeed, the IAS guidelines recognise that structural and other barriers may hinder immediate linkage to care, immediate patient evaluation, and immediate provision of antiretroviral therapy, but does recommend that testing sites and treatment sites work to resolve any impediments to the same-day initiation of antiretroviral therapy. And as many people in the room will know, one of the places where this is actually seen to be most difficult is in the American treatment cascade, where actually engaging people into successful therapy and keeping them undetectable drops off quite quickly, so they're aware of some of those barriers there. This is the BEVA guidelines. These are the British guidelines who recommend that we involve patients in making decisions about their treatment, recommend treatment for everyone with chronic HIV infection, and recommends that all individuals with suspected or diagnosed primary HIV infection are reviewed promptly and offered immediate antiretroviral therapy. And some debate about where we call the cutoff really for primary HIV infection. Most people seeing that immediate treatment is certainly needed within the first 4 weeks after infection, but certainly if we see someone up to 12 weeks, again, we would say that that's a reason to start therapy as soon as possible. So all of these recommendations also follow the 2017 WHO recommendations to start antiretroviral therapy on the same day as HIV diagnosis, or at the very least within 7 days of the diagnosis of HIV. And this guidance in turn is based on randomized clinical trials in resource-limited settings, showing that the provision of immediate antiretroviral therapy actually improves the uptake, improves retention in care, improves virologic suppression rates, and in one study also improved mortality rates. And in the US, pilot studies in several cities have shown that the offer of immediate antiretroviral therapy after diagnosis has led to substantially earlier linkage to care, earlier antiretroviral initiation, and a shorter time to achieving viral undetectability. So what's the rationale behind this earlier and earlier treatment? Well, the START study found that the risk of developing serious illness or death was 53% lower in the group that received earlier treatment with antiretrovirals rather than those who deferred therapy. And the rates of serious AIDS-related events as well as serious non-AIDS-related events were also both lower in the earlier treatment group than in the deferred treatment group. In addition, there's this feeling that immediate antiretroviral therapy may reduce the size of your viral reservoir, may have an impact on reducing ongoing problems with chronic inflammation, and it's felt that starting antiretroviral later in infection may be associated with less robust immune reconstitution. What we do find is that where people have used rapid antiretroviral therapy, patients often report decreased anxiety and an increased sense of control over their viral infection if they start antiretroviral therapy at the time of diagnosis. This is true for most people. I would say for some people the idea of a small minority, but for some people starting antiretroviral therapy too early actually makes them feel very medicalized. So it's about trying to find who the right people are for immediate therapy. So what evidence do we have? There's actually more evidence that's accumulated than the three studies I'm going to touch on here, but we're going to focus particularly on the data from Haiti and also on the data from 56 Dean Street in central London. So I think this is some really powerful data presented in 2016. They noticed that in Haiti there were high attrition rates from the time of HIV testing to the time of antiretroviral initiation and delays in treatment, leading to increased mortality, diminished recovery of CD4 cells, and a higher cost of treatment for opportunistic infections, as well as higher ongoing HIV transmission rates. So several things there that we want to target with better access to earlier treatment for HIV. And it was felt that the removal of requirements for lots and lots of visits, for testing, for more and more blood tests before starting antiretroviral therapy might actually decrease the amount of patients that were lost between the time of diagnosis and the time of therapy initiation. So they performed a study to compare standard versus same-day antiretroviral therapy. You can see the inclusion criteria there. People had to have a CD4 count of less than 500, and people were excluded if they had TB or a pneumonia, or if they failed a questionnaire that tried to examine whether or not they were ready to commit to lifelong antiretroviral therapy, or if they planned to transfer care out of the area. They were also excluded. You can see here the schedule of visits for both the standard group and the same-day antiretroviral group. So if we focus on the same-day antiretroviral group, they had counselling and antiretroviral initiation on day 1. They had physician and social worker visits at days 3, 10, and 17. And then at day 24, they had another visit to the doctor. And if you compare that to the group above, really the only difference was the timing of antiretroviral initiation, with antiretrovirals not being initiated in the standard group until day 21. And I think this is the most powerful slide with regard to the Haiti data. At 12 months, if you look at all of those significant p-values on your right-hand side, you can see that in the same-day group, there was lower mortality, there was a higher proportion of people who were alive and were retained into care, there was a higher proportion that was significant of people who achieved viral undetectability at both the 50 and the 1,000 copies per mil cutoff. So really compelling data here, I think, that early initiation led to much better outcomes, including improved mortality. So when we look at this example in a different setting, this is a very large sexual health clinic that many of you will have heard of in central London, 56 Dean Street. The photograph here is actually of their Express model. This is called Dean Street Express. This is where they perform rapid testing for sexually transmitted infections and bloodborne viruses on people who are asymptomatic, texting them their results within 2 to 4 hours after testing, and they've achieved a lot of success in rapid linkage to their clinic just down the road, 56 Dean Street, which is where you can initiate antiretroviral therapy, usually within 24 to 48 hours after diagnosis. And this was the standard pathway, so they looked at what they were doing in their standard pathway. They were seeing someone who was diagnosed, someone was having some fairly standard blood tests taken, including hepatitis screening, CD4 count and viral load. What this is showing on the bottom here is not when the tests were drawn, this is a timeline showing you when the results would come back when things were sent to a standard laboratory. So your viral load, HLA B5701, resistance test and so on might take a lot longer than your U&Es, LFTs and full blood count. And so there was a delay really in getting all of this information back before people could start treatment. And when we talked to treating clinicians in the UK, everyone was very anxious to move from this model. Well, surely we need all of these results before we start therapy. What if we don't know the hepatitis status? What if we don't know the resistance data? Surely it's crazy to start therapy before we have all of these safety bloods back. It's a slightly different scenario, but I often think of starting post-exposure prophylaxis in someone who's been at high risk of HIV infection, where we start that without any test results back at all, and we feel very comfortable about it. So we're very comfortable about the fact that we don't have their U&Es, we don't have their liver function, we don't always know their hepatitis status, but we're still very happy to give PEP if someone's been at high risk. But in this scenario, of course, they could be infected, so we have an extra consideration of worrying about underlying resistance or other problems. problems, but even so, I don't think we necessarily need all of those test results before being happy to start safe and well-tolerated modern antiretrovirals. So this is what they did. They looked at a new pathway to see if they could link people into care within 48 hours and initiate antiretroviral therapy. So this wasn't quite same-day initiation. They still knew that within 48 hours they'd have some basic test results back, including kidney and liver function, but they wouldn't necessarily have the CD4 count, the viral load, any resistance data. Is it important? It's done. Right. Okay.
No, they just disagree.
Okay. So they wouldn't have all of the viral-specific data back. So what happened? They looked at, they initially presented 127 patients who they diagnosed with incident HIV infection. Of those, 118 attended an appointment within 48 hours. And of those, 89 started antiretroviral therapy at that appointment. And we can see here the times it took to start antiretroviral therapy within 48 hours to 7 days, and so on. You can see the data there. And this is what they started, and I just wanted to explain this slide in a little more detail. If you look at the top there, the people who received a boosted PI, you can see that 54% received a boosted PI, and that's because only, this is the group who had therapy initiated before their resistance test was back, okay? And the only people that got a PI when their resistance test was back was 7 people who did have major resistance mutations, indicating that they needed a boosted protease inhibitor. If you look in the next two groups, people receiving an integrase inhibitor, people receiving a non-nucleoside, you can see that all of these people had their resistance test back before they were started on treatment. So there was still some caution. Clinicians were still nervous about starting an integrase or a non-nucleoside based regimen without resistance data available. Okay, that's what that really means. And of the outcomes, so of 55 people who started antiretroviral therapy in the first 3 months, 54 of these achieved undetectability, a cutoff here given of 200 copies, and 1 didn't, who actually had an L90M, who'd started a boosted protease inhibitor with Truvada, and then rebounded, and then subsequently was lost to follow-up. The summary of their data was that this approach to shortening the time between diagnosis and seeing a doctor could easily become the model of care across the UK, and in fact I think has been pretty widely adopted by some of the larger treatment centres, with still some caution in some of the smaller centres about earlier treatment. Rapid antiretroviral therapy initiation was deliverable, 26% in this example attending within 48 hours, and patients were of course able to decline rapid antiretroviral therapy if they were not ready. About 50% of the people that were in this trial or pilot rather, of early therapy were found to be in a stage of primary HIV infection. And it was noted as a caveat that all of the people who started early antiretroviral were mostly well-informed men who have sex with men, which pretty much reflects the cohort that do attend Dean Street. So it was felt that actually maybe this wasn't translatable necessarily to other populations and other risk groups. So we now think, what's the urgency? Do we need to start on the day of diagnosis, or is a slight delay acceptable? How many tests do we really want to get back? How many results do we want to get back before we feel safe about starting treatment? And is the urgency the same in chronic infection as compared to earlier HIV infection? And I'll just leave those questions for discussion perhaps a little later. So these are some of the things that patients say to us about starting therapy. I'm ready to start today. I want modern once-a-day treatment. I really don't want to be infectious. And this argument has got a lot stronger since we've had the U=U campaign around being undetectable, meaning that you cannot transmit HIV infections sexually. I want to preserve my immune system. I want to get on and get started with treatment so that my immune system doesn't get any weaker. And the other key question people often ask is, will this be a cure? If I start therapy now, will I be cured of HIV infection? Which leads to increasingly interesting and diverse discussions. But some of the concerns, often from treating clinicians, is it safe? What about resistance? And I think a key one, am I pressurizing the patient? How can I really tell if someone's ready to start therapy when I've only met them once and within 48 hours of a life-changing diagnosis? Some of the advantages are, as we've said, that people can take control of their infection, and we've mentioned some of these advantages already, but also I think people may modify their sexual behaviour, as well as knowing about U equals U. They may reduce the number of partners in the time immediately after infection. They may increase their condom usage to reduce the risk of other sexually transmitted infections, and these data are widely known. We know that diagnosis changes behaviour. We know that people who are known to be HIV positive reduce their risk of transmission to others. And so I think starting early really does give people an ability to implement behaviour change as well as taking medication. And then we have to think again, I think, on reflection about the difference about primary HIV infection and whether or not we really see this as a medical emergency. To me, I see the time of primary infection as a medical emergency and a time to really intervene and start with therapy. But again, this isn't necessarily widely adopted by all treatment centres for HIV. Just to conclude, some of the disadvantages might be, as we've said, that not all of the results are back. We might over-medicalise the patient. It may not be for everyone. They may have side effects. And we remain unclear as to whether people who are treated in this very early phase have better adherence or worse adherence. All I would say about treatment regimens is that actually I think we're becoming a lot more confident now about using integrase inhibitors in this early stage of infection because of the widely reported data about a paucity of transmitted drug resistance to the integrase inhibitor class. So there are clearly some very convenient drug regimens based around integrase inhibitors that are available now and may be very suitable for treatment at this early stage or after diagnosis. And I'm going to conclude here. This is repeating that data again, just to say that the resistance data we've seen from Dean Street would also further support use of integrase inhibitor resistance, and we certainly consider dolutegravir or perhaps increasingly bictegravir when we're thinking about early treatment options. So in summary, from the data I've presented and from what we've seen in clinical practice, we really feel that early linkage to care and early antiretroviral therapy initiation after an HIV diagnosis is deliverable, is safe, may give better viral suppression rates, may give better retention into care, better outcomes, less onward transmission of HIV, which really may impact on epidemic levels of HIV infection, and that increasingly we feel reassured to consider an integrase inhibitor-based regimen when we do initiate therapy before all of the other test results are back. Thank you very much.